Hello, I'm Marco Schiavone. I'm actually a young cardiac electrophysiologist working at the Luigi Sacco University Hospital in Milan. The importance of this analysis on heart failure patients in S-ICD is that we don't have specific data on this kind of population. We just have one trial, which is the untouched trial, that basically show that this device is a very good device in this kind of population. And so with our large retrospective registry, we try to find out if this data were confirmed and if this kind of patients will have a benefit from this device. The study design is a retrospective registry, which is the largest retrospective registry on the S-ICD in Europe. We basically enrolled 1,400 patients that were all analyzed retrospectively. The key findings of our study are that this device is a device that did not suffer from a higher number of inappropriate shocks when we compared the heart failure population versus the no heart failure population. So basically, the primary outcome of our study was the rate of inappropriate shocks. So we included in the HF population patients with heart failure and reduced and mildly reduced ejection fraction. Then we compared them with a non-heart failure population, and we found that in these two cohorts, we did not find a different numbers of inappropriate shocks. As for secondary outcomes, we found that as for device-related complications, heart failure patients suffer from a slightly higher number of device-related complications, but those complications were always or almost always managed in an easy way, and so patients did not suffer from a worse outcome in their failure population. So this device is kind of safe and effective in this particular setting. The take-home message is that of our study is that we can actually use this device in heart failure patients because there's an idea that maybe this device is suitable and very adequate for the young patients not suffering from several comorbidities, while often heart failure patients do need a transvenous device. But this is not completely true, and our study confirms that. Of course, our failure patient may need CRT in cases of left bundle branch block and need for a CRT. Sometimes they also may need pacing, and of course, in that case, a transvenous device will be needed. But in all other cases, when CRT, ATP, or pacing is not needed, the subcutaneous SCD is a very good device in this kind of setting, and we always have to keep in mind that whenever in the follow-up a heart failure patient are going to need for pacing or CRT, you can just extract the SSCD device without complications in most cases, and you can always upgrade to a transvenous device in the future. Sure, we need further research with a randomized trial that may confirm our study in a prospective and in randomized setting. And actually, a randomized trial will always be better in results than a retrospective analysis. But I think that we just open a road for further research, and of course. Even sub-analysis of the Praetorian trial or other randomized trial will give us a definite answer on the question whenever the heart failure setting will be investigated by other groups or also by our groups. Sometimes we're going to make a randomized trial.